Welcome to this session. This is a pre-recording session to talk about costs and outcomes of implementing quality improvement techniques under the Midwifery framework in Nairobi, Kenya. So this pre-recording session is to help students and faculty members who are not able to follow my live presentation during a workshop organized by Karolinska Institutet, for them to be able to understand some of the work that we've been trying to do with regard to costing quality improvement programs. And we're very happy to hear from you. Any comments from you? I really appreciate. My name is John Kirago. I represent a team of authors who have been working on a manuscript on the work I'm about to present. And we hope to be able to publish this work in the near future. So I'm doing a presentation on behalf of a team of authors, so this is not my work alone. So let's dive into the presentation. I'll be sharing the presentation in a second. Okay, now this is a presentation on costs and outcomes for implementing quality improvement practices under the Midwifery framework in Kayole Health Center in Nairobi, Kenya. Allow me to start with the operational definitions. So when we talk about cost in this presentation, we're talking about dollars, whichever currency, but we're talking about money that was invested to implement the change. When we talk about outcomes, we will be talking about observed changes from the baseline within the program. And when we will be talking about quality improvement practices, techniques, we are referring to 3 techniques of midwifery care: dynamic birth positions, skin-to-skin care, and delayed cord clamping. Lastly, when we talk about midwifery framework under this discussion, we are talking about a collaborative and evidence-based care provided by the midwifery by a midwifery-led team for women during their whole reproductive life cycle. Sustainable development goals have concretized the idea that countries should target to have less than 70 maternal deaths per 100,000 live births. The goals have also concretized the idea that countries should purpose to reduce neonatal mortality to as low as 12 deaths per 1,000 live births. To put this goal into context, Kenya, for example, one of the sub-Saharan African country, has reported a very high maternal mortality ratio of 362 deaths per 100,000 live births, and high neonatal deaths of 22 deaths per 1,000 live births. So if you compare the two, the goal and the Kenyan context, so we are saying Kenya is one of the countries that needs to improve towards realization of vision, a sustainable development goal of maternal and neonatal health. Poor quality of care has been implicated in resulting to high maternal and neonatal deaths. For example, a recent report by the Ministry of Health Kenya shows that only 60% of neonates are put through the breast within 1 hour after birth, further translating to poor quality of care, which could also explain why we are having twice as much in terms of neonatal mortality. So when you compare the 22 neonatal deaths to the SDG goal of 12, so we are talking about twice as much with regard to neonatal mortality. Therefore, quality improvement programs are warranted to be able to improve this situation. Therefore, we are here to report that dynamic birth positions and skin-to-skin care contact and delayed cord clamping that were implemented under the Midwifery framework in Kenya as part of the internet-based capacity building program in 4 sub-Saharan African countries were warranted to improve the Kenyan situation of improving quality of maternal health care. Besides, the fact that these techniques were warranted and the program was warranted, we went a step further and reporting to you the costs in this study, reporting the costs that was associated with the implementation of the 3 techniques of quality improvement in Kenya. The justification for cost analysis is the fact that sustainability of quality improvement programs are dependent on availability of resources, such as financial resources and human resources for health. Hence, there's need to document major costs and cost drivers of the implementation of these quality improvement programs in one study site in Kenya, so as to inform future planning and resource mobilization for future collaborative projects in similar resource-constrained settings. The objective of this study, therefore, was to measure the outcomes from the quality improvement interventions and to report on the cost associated with the change implementation. Specifically, the objective was to determine the outcomes of the quality improvement in this particular study setting in Kenya, to estimate the costs for the implementation of the practices, then to estimate the cost drivers and the cost per outcome for the implementation of the quality improvement program. The implementation of the 3 techniques in Kenyan study setting was guided by the model of change for improvement. The model of change for improvement guides that not all changes result in improvement. Thus, there's need to implement changes that can lead to improvement. So this can be ensured by following a PDSA cycle, whereby you are able to plan for change. You plan for change, you do the plan, then you study the change, then you act, known as the PDSA cycle. So putting the PDSA cycle in our context for the quality improvement project. So the planning was done for the capacity building on the midwives framework and for the implementation of the 3 techniques. Then implementation of the plan was done on the capacity building and the implementation in Kayole Health Center. Then data was collected and was studied to be able to study changes from the baseline and to estimate the costs. And finally, from the results, we were able to ask ourselves whether the changes that we realized were important or not. And hence we were able to give recommendations. So throughout this presentation, I'm guided by the model of change for improvement in reporting the methods, the results, and the recommendations based on the PDSA cycle. So the methods for this study followed a pre-test and a post-test design, whereby data was collected at baseline to be able to measure the level of practice for the 3 techniques of care, of midwifery care. So the baseline established where the facility was faring with regard to the 3 practices. At the beginning of week 2, a training package was introduced in form of an interactive in-person lecture and practical workshop session. Was delivered to facilitate midwives on the 3 techniques of midwifery care. Under a midwives framework, a midwives team formation was done, and weekly follow-up and visits to support the clinical practice, and weekly data collection was done until the 12th week of the project implementation. Just to emphasize, when we talk about the midwives framework under this discussion, we're talking about collaborative care led by midwives in delivering reproductive health to women. So the midwives framework requires that midwives collaborate. Midwives provide evidence-based practices such as skin-to-skin care, dynamic birth positions, and delayed cord clamping. They work in interdisciplinary team, and they have to continually improve care for women. So that's the midwifery framework that was employed in even formation of the teams for the implementation of the 3 techniques. The 3 techniques that were introduced at week 2 were the skin-to-skin care, delayed cord clamping, and dynamic birth positions. Literature and evidence with regard to their benefits was as well passed on, explained, and the right technique of the practices was also demonstrated to the facility midwives with a particular emphasis on dynamic birth positions, because prior to this, to the workshop, to the quality improvement workshop, none of the facility midwives was practicing any of the recommended dynamic birth positions. So as we will see, when it comes to the cost implications, much more time was spent demonstrating and explaining to the midwives on dynamic birth positions. So this is one of the sessions, antenatal sessions, whereby we were trying to demonstrate to the mothers on techniques of dynamic birth positions. With regards to costs, so we documented time the facility midwives spent while participating in the demonstration, in the workshops, and we translated that time into costs. We also recorded the materials and the equivalent costs, logistical cost, program cost, were also documented during the implementation. 3 cost scenarios were developed. Scenario 1 was a scenario whereby the facility, let me repeat. Cost scenarios were developed from a health facility perspective. But in scenario 1, time cost of the participating staff was considered to be the only cost the facility was incurring, given that the facility had external support, external funding, and facilitation. Under scenario 2, time costs, as well as the facility incurring logistical, material, and trainer service costs, was accounted for under scenario 2. So scenario 2 is a scenario whereby the facility had incurred extra cost apart from staff time cost. The facility went ahead to hire, to facilitate the trainer being trained elsewhere, but coming to the facility, being to train and to lead this particular change management for the improvement of midwifery care. Scenario 3 is a scenario whereby we assume the facility did not have any external support, or it had very minimal external support with regard to the capacity building program and even the time costs for its staff. On to the results. After the the 12-week implementation period, the results show that the dynamic birth positions and the skin-to-skin techniques were not faring well. Their baseline was at 0, while the delayed cord clamping, its baseline was at 80%. After the introduction, after week 2, where we introduced the training material, and we formed a midwives team, there was an adoption with regard to the 3 techniques of quality improvement, with dynamic birth position and skin-to-skin care, moving from 0% to 45% adoption for dynamic birth position, and around nearly 60% for the right technique of skin-to-skin care. So in the course of the project implementation, the level of adoption went down at around week 8, and this was attributed to staffing, whereby there are a number of staffs who didn't participate in the initial workshop, and now they were coming in, and knowledge transfer from the staffs who had been trained had to happen, and it was happening gradually. So we decided to organize another workshop at week 8, just to be able to sensitize the staffs who had just joined in the team and the staffs who had been newly employed during that time, to be able to catch up and to be able to practice like the rest. However, none of these practices went to 100%, even at the end of the project implementation. The same results were presented in a tabular form, showing that the average adoption for dynamic birth positions was that 6% and 79% for skin-to-skin care. With regard to delayed cord clamping, the adoption was not, there was minimal adoption. In fact, there was no adoption from the baseline. The baseline week was 80%, and after the 11th week, within the 11 weeks of training, the proportion of adoption was 78%. So comparing that to the baseline, there was minimal change from the baseline. It was actually -2%. So, and we attribute this to the fact that, I mean, the baseline was initially acceptable, but our follow-up workshops revealed to us the reasons why the midwives were not fully practicing a delayed cord clamping. So, which they said was due to the fact that they had known that you do not practice delayed cord clamping for mothers who are giving birth and they're HIV positive, because they believe that would increase the exposure of the babies to HIV infected blood. So that was actually the reason some of the midwives gave in one of the focus group discussions. The major cost drivers for the quality improvement project have been summarized under each scenario. So scenario 1 is in column 3, showing that the staff time costs was the major cost driver. Staff time cost was a major cost driver from the health facility perspective. And the scenario 2, which is in column 4, the major cost driver was the cost for hiring a trainer from a capacity building program, and the cost of facilitating that trainer to come and lead this change, the change of the midwives being trained on the 3 techniques of care and adopting the practice for 12 weeks. Under the third scenario, which is a scenario whereby the facility is assumed not to have very minimal external support, the major cost driver was the costs of the capacity building, invested in capacity building to produce or to have one graduate midwife who can implement this change. With regard to the cost per outcome, and these are intermediate outcomes, under scenario 1, it costed $2.3 to have midwife adopt, to have a birth, adopt a dynamic technique of birth, dynamic position of birth. And it also costed $0.50 for particular delivery to practice skin-to-skin contact. Implying, it's very, very, it's not expensive, to implement such an important technique such as skin-to-skin care. Then under all the other 3 scenarios, under scenario 1, given that we didn't have any change upon implementation, upon trying to sensitize staff on delayed cord clamping, so we didn't have cost per outcome because we didn't have any outcome for delayed cord clamping. Under scenario 2, similarly, we had only $6 for adoption of dynamic birth position per birth and $1.4 for adoption of skin-to-skin care. Under scenario 3, the costs went higher, took $38.5 to adopt dynamic birth position from a health facility perspective, and $8.8 to adopt skin-to-skin care under the health facility perspective. So in our conclusion, the implementation of the dynamic birth position and skin-to-skin care practices under the midwife framework was found to have intermediate clinical benefits. And by intermediate clinical benefits, we are referring to the adoption of techniques of midwifery care, of quality improvement, such as dynamic birth positions and skin-to-skin care. So it is feasible actually to implement those techniques under the midwife framework for quality improvement. In addition, it was found that this implementation was achieved, the benefits were being achieved at reasonable costs for a resource-constrained health center like the study setting, whereby the average wage of a midwife, hourly wage of a midwife in this facility was $4.7. So comparing this with the costs in scenario 1 and scenario 2, this was considered to be, the implementation costs were reasonable. They were not way above how the much a midwife earns in 1 hour in that facility. In scenario 1 and 2, which assume full funding support, scenario 1 and 2, which assume partial funding support for the capacity building program, the major cost drivers were staff time at 72%, and logistics and material costs and the trainer service fee at 56% respectively. Scenario B, where zero funding was available for the facility, the major cost driver was capacity building program to graduate 1 trainer to be able to drive that change. So why is this discussion of importance to us? Such a cost analysis identifies areas for potential cost savings, and identifies different cost elements and alternative funding sources for quality improvement programs. In addition, the adoption of the aforementioned techniques has been cited in literature to improve quality of maternal health care. For example, the adoption of skin-to-skin care in literature has been shown to prevent hypothermia, enhancing exclusive breastfeeding. So while the outcomes realized in this study were intermediate outcomes, so literature has linked these intermediate outcomes to actual disease outcomes and clinical outcomes, which are very, very important for the overall maternal health. And further to disease outcomes, the adoption of skin-to-skin care has also been linked to enhancing cost savings, averting disability-adjusted life years, and has been linked to neonatal survival, which are generic outcomes that can be used to compare which can be used for cost effectiveness comparisons and cost utility comparisons. So it's the same thing for adoption of dynamic birth positions, which have been linked in literature to enhancing realization of disease outcomes and general health outcomes, such as reducing incidence of operative delivery, cesarean section, episiotomy, and pain, and shortening the second stage of labor, and which contribute now to reducing maternal deaths, enhancing quality of life, reducing cost associated with complications of birth. Lastly, the adoption of delayed cord clamping. Although in our quality improvement project, we found no effect on the training because the baseline, I think, was acceptable at 80 with a room for improvement. So this technique, when fully improved, it has huge potential. I mean, to reduce infant anemia, intraventricular hemorrhage. Apologies for that disconnection. Apologies for that. Apologies for that, sorry. So I think we can continue with the discussion. I think in this particular slide, I think my emphasis was on the fact that the intermediate outcomes that were achieved within the quality improvement program have been linked to actual disease outcomes, actual health outcomes, maternal health outcomes, and hence the justification for having achieved these particular intermediate outcomes, namely the adoption of skin-to-skin care, the adoption of dynamic birth positions, and even the potential for putting more effort for the facility to be able to improve and to sustain the practice of delayed cord clamping. These intermediate techniques can impact maternal health care. They can impact maternal health outcomes. They can reduce cost associated with complications of birth. And generally, I mean, they can justify, I mean, further investments in maternal health care. Therefore, future improvement programs should go beyond intermediate outcomes to measure clinical health outcomes resulting from such improvement on the level of adoption of midwifery practices. So we recommend that to add to the body of knowledge on the link between the magnitude of change in the intermediate outcomes, such as the ones realized in this study, and the associated changes in health outcomes, we recommend future researchers to be able to, to go beyond what we have done and to be able to link the intermediate outcomes to disease outcomes and to generic outcomes, such as how, for example, the adoption of skin-to-skin care within, say, such a setting, how that would contribute to the reduction in disability adjusted life years that result from complications of birth. And based on literature review, the intermediate outcomes realized in this project have the potential to improve maternal health care, and hence this need to scale such quality improvement collaboratives. I want to thank you very much for taking the time to go through this pre-recording session. I'm hoping for a comment from you just to help us improve on the manuscript, and even to maybe we can collaborate in scaling and in doing follow-up studies on what we've done. Thank you very much for your time. So this is the team that conducted the quality improvement project at Kayole Health Center. And I'm very grateful for the team for giving me the opportunity to be able to propose the need to conduct cost evaluations associated with quality improvement, and for us to be able to report, to be able to come up with such a manuscript. Thank you very much, team. Thank you very much, everyone. And I hope to hear from you very soon. Thank you. Thank you.